Musculoskeletal is commonly tested on the NCLEX. The best way to master them is to compare disorders. In this video, I'm going to use NCLEX practice question, select or apply SATA questions, comparing them in the next generation NCLEX format. You want to stick around and watch this video. By the end of this video, you'll know most musculoskeletal disorder and how to compare them. We're going to use common sense approach to master them. Are you ready? Let's get to it. First question, you have to know the difference between osteoarthritis and rheumatoid arthritis. I want you to stop the video and answer the questions on your own. Then compare it the way I'm going to approach it. But like I said, common sense strategy. That's the thing. But we are using NCLEX SATA questions to answer it next generation form. When you see this, don't run away from it. Don't over-select. What you need to do, take away the table and ask yourself, is this associated with osteoarthritis or rheumatoid arthritis? That's all. It's just a table. So what is the problem? Read the question from the back and then you identify which findings are consistent. Is it consistent with which disorder? The next is reviewing medical record of 2 clients with musculoskeletal disorder. If you take osteoarthritis, can you see morning stiffness lasting less than 30 minutes? Or the joint, both joints are involved, or you have evidence nodules, or elevated ESR or CRP, or this is associated with autoimmune. Do the same thing with rheumatoid. Then leave the table alone. If you know it's associated with it, select it. Unfortunately, you have to select one from each level. This is what the NCLEX want you to do. You can't leave a level or a row without any answer choice. And then the next strategy is what? Look at it. Osteoarthritis, rheumatoid. We all know rheumatoid disease is an autoimmune. Just by that, we pick this one. And it's not infectious, it's inflammatory. And what is the problem? Osteoarthritis is not associated with inflammatory disorder. Therefore, CRP and ESR is associated with rheumatoid. But most of the time, rheumatoid is both joints. Symmetrical disease, therefore that one. Who is going to have stiffness? Who is going to have stiffness less than 30 minutes? It's mostly osteoarthritis. Rheumatoid lasts longer. That's why you ask them to sleep flat in the hardboard mattress. If you take a look at both fingers, there's going to be nodules, like scar tissue nodules, basically bumps in the distal phalangeal. Your phalanx, your hand, which is the phalanx, is divided in different joints, right? And this go to your hand. The joints have names. The distal and the proximal joints have names. You can have butchered node associated with what? The proximal and the distal is Heberden's nodule, all associated with what? Osteoarthritis. This is what they look like. Write the concept down. When you see your question, remember these 2 conditions. I've given you 2 concepts. Everything you need to know most of the time associated with osteoarthritis. NSAID is good for osteoarthritis. Next question. And this should identify which findings are consistent with each disorder. And this is assessing 2 clients admitted with what? Acute joint pain. What is the problem? Who has gout? Who has septic arthritis? Who has all these things? Elevated uric acid, fever, leukocytosis, sudden severe pain at the great toe. Drainage is prevalent, and the treatment of choice is colchicine. How do you analyze it? Look at the name, gout. I don't see infection there, but I see septic. Septic is an infection. Forget about the arthritis. It's an infection of the joint, whatever. And this you can use to answer the question. Infection, I'm looking for what? Fever, leukocytosis. Boom, septic arthritis. Gout is not infectious. It's associated with other things, and one of them is uric acid level. Why would they list great toe? A septic arthritis is the whole thing. That's why there's no name there, no specific joint. If they listed one joint, which is the great toe, you know it's gout. If the joint fluid is purulent, infectious, is septic. Treatment with NSAID, mostly gout. This is what your table should look like. I know your answer choice resemble this. If it doesn't, go back while you mix it and see the way I approach it. Like I said, common sense strategy to answer these NCLEX SATA questions on musculoskeletal. Number 3, and then you identify which findings are consistent with each disorder. And then review diagnostic finding for client with what suspected bone disorder. You have osteomyelitis and bone tumor. We're going to use the same thing. I divide this and have osteomyelitis, some form of infection. Bone tumor, there's no infection. Therefore, if I see fever, osteomyelitis. If you have infection, it's going to hurt. If you have tumor there, it's going to hurt. Therefore, both of them are going to have pain. If there's infection, elevated white count. Who's going to have unexplained weight loss? When you have infection, you don't have unexplained weight loss unless it's chronic, but mostly not unexplained. It sounds like cancer. And if you need to do a biopsy to make a diagnosis, most of the time we'll rule out cancer. Common sense, NCLEX practice question, SATA question, musculoskeletal. Try to think that way when you see a table. Don't memorize this. These are concepts on musculoskeletal, but you don't have to overthink it. Break it down. Adapt NCLEX way. You've seen compartment syndrome. You've seen DVT. If I put in a table form, how can you compare them? Don't run away. Don't even think about thinking. And next, should identify which findings are consistent with each disorder. The next, assess a client with leg trauma. Who do you think have compartment syndrome? DVT, deep vein thrombosis, deep vein, severe pain, unrelieved by analgesic. When you have DVT, it has nothing to do with pain. I give it to you, it doesn't resolve the pain. Compartment syndrome. When you just move your leg, it's hurting because the muscle are dying. That's passive pain with passive range of motion. And if there's no blood flow to your leg, I know deep vein is mostly vein problem, it has to be compartment syndrome. And a positive hormone sign, what do you think? This is associated with specifically for DVT. And a warm cough is what? DVT. Immediate surgical intervention, compartment syndrome. You don't need surgery right away for DVT. They need anticoagulation. So that's your answer. Did you get the same thing? I know you did. And this is the question. A lot of people will mix it. I know which answer choice they will mix it. I will give you a clue. And then you identify which finding are consistent with which disorder. And this is assessing 2 clients with bone disorder. Vitamin D, decreased bone density, bone softening, fragility fracture, hypocalcemia, associated with osteoporosis, osteomalacia. If the NCLEX give you osteoporosis, expect to see this. This is where people is going to get a mistake. This one, vitamin D deficiency, fragility, and hypocalcemia. You have to know the difference between the two. Osteoporosis, I'm going to say something if you never heard it. Most people with osteoporosis, their calcium is normal. The problem is the bone is reabsorbed. So we're removing most of the bone rather than putting it down. There's more reabsorption than how we make the bone. So the bone will become brittle, soft. The density is decreased. In the process, that causes osteoporosis. It's porous. Osteomalacia is softer. The bone is soft, right? And it's due to what? Vitamin D deficiency. So they have vitamin D deficiency leading to reabsorption issue. You cannot absorb calcium in the GI tract in the kidney. So vitamin D deficiency lead to calcium reabsorption. If you have vitamin D deficiency, you're going to have what? Hypocalcemia. People always make a mistake. If you have hypocalcemia, does not lead to deficiency in vitamin D. But if you have vitamin D deficiency, you're more likely to have hypocalcemia because you cannot absorb your calcium. So vitamin D deficiency and hypocalcemia is associated with osteomalacia. In osteoporosis, your calcium is normal. It's just you trying to absorb most of the calcium more. The bone is being chewed than being laid down. That's why we try to help them prevent the bone breakdown, but you can also give them calcium to improve. You can also give them vitamin D to have more calcium, right? So that the bone can use it more to build the bone faster than is being chewed. So bone density is osteoporosis. Which bone is soft? It's mostly osteomalacia. Which one is going to break easily? This is the key. Which bone is going to break easily? That is another one. Which bone is going to break easily is not the one that is soft. It's the one that is brittle, right? It's because the density is not strong. And therefore, osteoporosis is the one that breaks easily. Osteomalacia causes more bone pain and they cannot walk. They have bone pain. They cannot walk because the bone is soft, but the bone that is brittle break easily. So fragility fracture is like you fall down a little bit, you break that. That means less trauma. You lifting something and you break your back. Minor fall, you break your back. That's fragility fracture. That is associated with what? Osteoporosis, not osteomalacia. Watch this video, this section, question 5, and write the concept down. This question illustrates the conditions that you may see, never seen it before, but you can't handle it. Trust me, I will break it down the way you should approach it. And then you identify which findings are consistent with each disorder. And then evaluate client reporting upper extremities numbness. 1. Carpal tunnel. 2. Cervical radiculopathy. Numbness in the thumb, index, and middle finger. Positive feeling test. Neck pain radiating down the arm. Symptoms worse with wrist reflection. Symptoms worse with neck movement. Which of these do you think is associated with this condition? I'll give you 2 words. After that, you can answer this question. Carpal tunnel is associated with your wrist. Cervical, that means your neck. So the problem is in your neck. That's all. Therefore, based on that, if I say I have numbness in my thumb, index finger, middle finger, this is associated with carpal tunnel because it's near your wrist. It's most likely to move from your wrist. Radiculopathy means radiating. So you have neck pain that goes somewhere. This one does not say it goes anywhere. It's a numbness in the thumb, index, and middle finger, carpal tunnel. Feeling test is specific to carpal tunnel. That means if you flex their wrist, they're going to have pain. If that is the case, symptoms is going to be worse when flexing your wrist. That's all carpal tunnel. I said neck. I see neck pain radiating to your arm, cervical radiculopathy. I said neck. Neck movement, your pain get worse, cervical radiculopathy. This is the way you should do it. And let's evaluate 2 clients with sports injuries. Sometimes you see the sports injuries, we interchange them all the time. They are not the same. Once again, they are not the same. And then you identify which findings are consistent with each disorder. Sprain and strain. Sprain and strain. Ligament injury, muscle injury, occur commonly at the ankle. Muscle spasm present. Treatment with what? Rise. What mean? Rest. Ice. Complete, right? Then you elevate it. Compression. That means what? Rest, ice, compression, and elevation. Which condition is associated with it? You have to know the definition of a sprain and a strain. And the best thing to think about is you strain a tissue that is bulky in nature, which is what? Oh, the easy way is simple, straightforward. We sprain our ankle. Why? There's ligament. All of them are ligaments. The ligament hold the ankle together. If this is your leg and this is the ankle, most of the time it's all ligament. There's no too much muscle there. We strain muscle. So straining of the muscle and spraining of what? Ligament. Therefore, ligament injury is associated with the sprain. Muscle injury is associated with the strain. which occur at the ankle. Told you sprained something. Muscle is going to have spasm. It's a strain problem. Which one require treatment with rise? That means rest it, height it, compression, elevation is both of them. Both of them need that treatment. Don't forget them. Sprain is a ligament and a strain is a muscle problem. This is the key. Number 8, what is your score? I know you get 7 out of 7. This is another condition too. You should not confuse them, and then should identify which findings are consistent with each other, and then assessing the client after long bone fracture. Who has fat embolism? This is pulmonary embolism. What are the signs and symptoms you should be looking for? Petechial rash on the chest, sudden dyspnea. These occur within 72 hours after fracture. Hypoxia, neurological problem. Common sense approach. If you can't answer it, it's okay. But let's see the way I'm going to approach it. Of course, both of them have embolism, and there's fat here in pulmonary. That is telling you that specifically fat embolism can lead to pulmonary embolism if the fat gets to the lung. But pulmonary embolism means a lot. There can be so many things. When they give you fat, they mean specifically associated with the fat. Of course, both of them goes to your lung, therefore hypoxia. Both of them go to your lung, therefore they're going to have sudden dyspnea. Now, petechial on the chest, when you have PE, you don't have petechial on your chest. That means this is specific to the fat embolism, which will occur right away after fracture, not immobilization, fat embolism. Which one will lead to what? Neurological confusion, specifically to fat embolism. So fat embolism, they have bone fracture, petechial on the chest, neurological symptoms. That is the difference between pulmonary embolism and fat embolism. And as I assess a client after patient fall down. How do you know dislocation or a fracture? Bone hand separate. The joint is deformed. There's crepitus. The leg is shortened. And both of them we need to immobilize. Which one? Very, very important to compare the difference. And think about it. What is your answer choice? How do you know this is dislocation, this is fracture? Please know this concept. Bone ends are going to separate. Think about it. A fracture will cause the bone to separate. Joint deformity associated with dislocation because there's no fracture. And the crepitus means if you push on the joint or the bone, it's going to make sound, mostly if it fractured. If it fractured, the length is going to be ununiform, therefore shortened. And which one we got to immobilize both? Both of them, we got to immobilize them. That means because they dislocated and fracture, we should not let them move anymore. That's the way you answer this question. That's the concept. And the last one, I know you're keeping your score. What is the difference between scoliosis and kyphosis? You may see a question on it, on the kid, and you got to figure out, how do you know? That's all. Which one is lateral spine curvature, right? Kyphosis versus scoliosis. Which one is the lateral side? Think about it. Scoliosis is the lateral. When you look at them, right, they are like that. That's scoliosis. Which one is going to have hunchback? Consistent with kyphosis. Which one is going to have uneven shoulder height? Scoliosis due to the curvature, right? And when you look forward on the upper back, what is going to go on is kyphosis. How do you know patient has scoliosis? Let them bend down and touch their toe. That's what we call Adam test. Bend forward, and this is scoliosis. 10 questions. NCLEX practice questions, NCLEX review questions, NCLEX questions and answers. You see common sense, SATA questions, next generation NCLEX, musculoskeletal, concept analysis. Know each of them, know the concept. Some of them we talk about management and master those concepts because they may help you someday. Take care of yourself. Bye.